So much, Alana, for that introduction, and thank you everyone for attending today, our last webinar. Um, Today I will be talking about medications used in insomnia. Of course, now that we're talking about insomnia, we're talking about a non-motor symptom. So a non-motor symptom that actually a lot of people that do have Parkinson's disease, it comes up quite a lot. I get a lot of questions about it at work, and I get it from individuals, of course, with Parkinson's, as well as their care partners, their caregivers, and from individuals as well that don't have Parkinson's. So I thought it would be a very interesting and important and hopefully useful topic to talk about. So yeah, let's begin. So often with Parkinson's, there is different sleep disorders. Today, I will be speaking specifically about insomnia, but of course, there's also excessive daytime somnolence, there's REM sleep behavior disorder, and restless leg syndrome. So why discuss insomnia? Obviously, like I said before, it's the most common non-motor symptom that individuals with PD complain about. It has an impact on our overall quality of life and well-being. So of course we notice it right away if we don't get that good of sleep the night before, right? It affects our ability to function the next day. It affects our mental alertness, being able to engage in exercise, ability to interact with their friends or family, just task around the house. It makes us feel sluggish, and we notice it right away. So it just sits on you and it affects you for the whole day. And in addition to that, of course, sleep is important to everyone, right? So not just ourselves, but of course, it can affect our care partners and caregivers, especially if they're sharing the sleeping space with us. So I hope that this presentation is useful to everyone involved. So there are different types of insomnia. There's sleep onset insomnia, where people find that it's difficulty falling asleep and actually getting to sleep. So you're just kind of tossing and turning. But then there's also sleep maintenance insomnia, where people find that they get to sleep okay, but then they find that they have difficulty staying asleep. So they're waking up, frequently throughout the night. So with the frequent awakening in the night, it can cause and lead to excessive tiredness during the day. And because of these frequent awakenings, it actually disrupts our natural sleep cycle and how we progress through the different stages of sleep, right? So because of that, we aren't spending as much time in each part of the different stages of sleep. So overall, you're spending less time sleeping, more time awake, and then you feel those effects the next day. With sleep maintenance insomnia, that is what individuals with PD, they experience that more than actually having trouble getting to sleep. So that's why we're talking about it today, and possibly different strategies to help navigate that. So with insomnia, it's a multifactorial etiology. So essentially different causes or different reasons and different factors can contribute to us having insomnia. So the first one I mentioned here is just changes in the brain that affects our sleep regulation. So essentially just the degeneration of the sleep promoting and the parts of the brain that's responsible for setting up our circadian rhythm to help actually promote sleep and for us to actually get to sleep. Those changes in the brain will bring about insomnia. So essentially changes in our sleep architecture in a way, and just more fragmented sleep. Often, like I said, primarily due to PD. In this case, that's the non-motor. It can also be due to rigidity. So obviously in cases where people are experiencing any stiffness, cramps, spasms, or muscle pain, of course that rigidity in the middle of the night can wake you up. And often pain is associated in some form with the stiffness, cramps, spasms, and muscle pain. It can affect different parts of the body. Some people will complain that it's their calves or their neck or their back is where they might experience the pain during nighttime. So pain essentially during the off periods, right? So even first thing in the morning when you're getting that dystonia, that kind of cramp spasms that you might get, that could obviously come with pain. And in some cases, pain can also be associated with dyskinesia as well. We have tremor, right? The motor symptom of Parkinson's. We have possible causes for insomnia can also include side effect of medications, and I'm talking about both Parkinson's medications as well as medications that aren't used for Parkinson's, right? So certain mood medications can be stimulating as well. Restless leg syndrome can also cause insomnia and contribute to that. We have our mood, right? So low mood, if we have anxiety, the thoughts that keep us up at night, the anxiousness can keep us awake. And we have hallucinations and confusion. So in some cases, as I mentioned before in a past webinar, hallucinations can come from dopaminergic medications, so such as levodopa and the dopamine agonist. And side effects, like I said, I think with the dopamine agonist, hallucinations might be more prevalent in some cases. So you can get those vivid dreams. In regards to hallucinations and confusion, they can come as a result of different things, a combination of possibly just changes in our cognition, the medications, as I just said, our age, just progressing disease, lack of sleep. So there's different factors. Hallucinations can also occur due to possibly a urinary tract infection, right? So there's just definitely different factors that we would have to assess. But regardless, with hallucinations and confusion, people find if they're that frightening, of course, you would have trouble getting back to sleep or even preventing sleep because they can be quite disturbing and they can come in different forms, right? It could be shapes, it could be shadows, it could be people, it could be animals. So it's just something that obviously is keeping you up at night. And then we have nocturia. So that's just the frequent urination at night. So you find yourself having to get up more than once at night to use the washroom. Can also contribute to our insomnia. So in regards to the approach to managing insomnia, I'm just going to go through the different steps, but essentially I use these steps for everyone, whether or not they have Parkinson's disease or not. And I always want to highlight the non-drug measures. Every individual I speak to, I always want to see what their sleep hygiene is like, what they're doing before bed, what their routine is, when they're exercising, if they're taking naps during the day, because those are one of those things that, like, the sleep hygiene plays such a big role. After that, I look at someone's overall medication regimen. So with Parkinson's disease, I want to make sure that they're getting adequate management of their motor symptoms overnight. And I also will assess their other medications as well that might interfere with sleep. So, making sure that you got good motor control during the night is important. But if, like I said in the past presentations, it's important what time you take these medications as well, because some of them can be quite stimulating. So if you take them too late in the day, you'll be up at night because you'll be wide awake and you'll have trouble getting to sleep. And like I said before, there's also medications that are not used for Parkinson's that can interfere with sleep as well. After assessing those, if there's still different factors, I might have to refer because there's other issues that can be contributing to insomnia as well. So to start with non-drug measures, first one I want to start off is just always trying to maintain a regular sleep schedule. So you want to go to bed and wake up at the same time every day to get into the routine of that, so it's consistent. Exercising in the daytime. Exercising has, of course, we know that it plays such a big role in helping with our motor symptoms and making sure that we keep our ability to engage in exercise and really get a good workout. But with exercise as well, it can actually help us maintain good sleep, and it actually helps us sleep better at night when we're exercising in the daytime, because you feel tired in the evening because we're getting, blood and oxygen to our brain, waking us up during the day, but then making us feel tired at night. With exercise, they say in the daytime, I think I would say roughly, I've heard before that not exercising within 6 hours of bedtime. So maybe earlier in the afternoon, late afternoon, but not right before bedtime. And then the next one would be limiting naps to 45 minutes or less and earlier in the afternoon. So I say 45 minutes or less. I know some people's sensitivities are different. Some people will be like nothing more than 30 minutes because when they've taken a nap at 2 p.m. in the afternoon for 30 minutes, they're able to get to sleep. But anything longer, anything after 3 p.m., that's when they start finding themselves in a position where they're tossing and turning and they're not really getting anywhere. So definitely, if I was to take a nap, I would try to not nap after 3 p.m. because once you start napping at 4 or 5, you're just in a territory where you might actually have trouble sleeping afterwards. And then with the bedroom, you always want to keep the bedroom for sleep and intimacy. Hard rule in this case, it'd just be best to associate the bedroom for sleep and intimacy, because if you start working or reading or watching television in bed, it just breaks that, and then new habits are being formed, right? So make sure that you keep your bedroom for sleep and intimacy. And the next one would be avoid looking at a screen 1 hour before bed, which is hard. I know, just especially during this time when we always have our phones and tablets in front of us, it's really breaking the habit of maybe before bedtime, sitting in the living room, sitting in your den or office and just reading under, a light so that you can focus on just your pages, just paperback, right? So just reading or maybe taking a bath, meditating before bed, but just essentially not looking at a screen 1 hour before bed because it can be quite stimulating. More non-drug measures would be no caffeinated beverages after 4 p.m. And this includes tea as well. So anything with caffeine, just try to avoid after 4 p.m. When I say being mindful of alcohol intake, essentially with alcohol, of course, it can make you sleepy and it can make you sleepy and wake up early rather. In some cases too, alcohol can disrupt our sleep, right? So we might find that we're waking up at 2, 3. So we're not getting that same amount of sleep, even though we're falling asleep early. So of course, some people do like to have a glass of wine with dinner, that's fine. But if you find that, a few glasses, or if you're, drinking a little bit more, if it starts affecting your sleep, you might just have to cut back or maybe just save it for certain nights where it's just 1 glass. So just things to be mindful of. We also want to think about our fluid intake, right, before bedtime. I put 2 to 3 hours before bedtime because it's different for everyone. And I've just seen different sources too, where some is, 3 hours before bed, some is 2. So I usually leave it up to just the needs of the patient and what works and what doesn't work for them. And I think 2 to 3 hours, honestly, is a good range. In cases where you can't sleep, it's recommended that you actually get out of bed. If it's been 15 to 20 minutes, you should relocate. If it's been 30, definitely. And when I say relocate, if possible, I'm talking about maybe moving out of the bedroom completely, sitting in the living room with just a little bit of light, maybe doing some light reading until you're tired, and that's when you go back into the bedroom and try to get back to sleep. But you don't go back into the bedroom until you're feeling tired again. I say relocate if possible because for some people, mobility is an issue. So even if you have just like a chair set up in your room, in the corner of your room, you can of course just get out of bed, sit in that chair until you're feeling like you're tired again. And that's when you turn off the light that you might have on, and then you go to bed and go to sleep. And then the next one here is get daylight exposure. So natural light, it's important because light helps us be alert and it helps, helps wake us up. So essentially light is important because light, it helps our sleep-wake cycle in the way that it helps synchronize. Light keeps us awake, keeps us alert during the day. So it really helps in that regard. And then more non-drug measures. So in this case, think about comfortable bedding, right? Just nice, cool sheets. Make sure the temperature of your bedroom is a temperature. It's not too cold where you have trouble getting to sleep, but not too warm where you feel like you're having to take off layers. So just comfortable bedding, comfortable room temperature. Satin or silk bed sheets and pajamas. In that case, the reason for this is it just helps you readjust. It helps you turn over and just switch positions easier during the nighttime if you need to reposition. In some cases, people might need to talk to an occupational therapist about getting assistive devices installed in their bedrooms, like rails, just to help with moving and turning if satin and silk bed sheets and pajamas aren't sufficient. And then we have another option would be CBT, or cognitive behavioral therapy. Essentially what this is CBT it's a technique that helps people change their patterns of just negative thinking and behavior. So in this case, you would be working with a cognitive behavioral therapist, and they would help you just replace your anxious thoughts that's related, or just your anxiety related to poor sleep, with positive thoughts, with associating the bed with being asleep. They might use different strategies such as stimulus control, sleep hygiene, sleep restriction, or relaxation techniques. So that could also be an option as well. That's a non-drug measure. After, discussing the sleep hygiene, I talked before about optimizing your motor control overnight. So in some cases, if you're waking up at 2 to 3 in the morning, is it because your Parkinson's meds have worn off? Are you experiencing that tremor, rigidity or stiffness or pain, possibly due to rigidity, that's keeping you awake? If you're experiencing those symptoms, it might be due to wearing off. So some strategies to help mitigate that would be for some people, they're taking a controlled release levodopa, carbidopa at bedtime, right? So they're getting that symptom management throughout the night so they can readjust, change positions, at 2 to 3 a.m. a little bit easier, and it doesn't wake them up. For some people, it might having a dopamine agonist in their treatment regimen. Before, in the last couple presentations, I spoke about entacapone as well, right? Because entacapone essentially prolongs the effects of levodopa, so it doesn't get broken up or inhibits the degradation or the breakdown in the periphery before it makes its way. The levodopa makes its way into the brain. So that could be an option in the regimen. And for some people, they might have an as-needed levodopa, carbidopa, immediate release dose for nighttime, right? That they're taking in the middle of the night when they're having trouble getting back to sleep, or they find themselves waking up. And of course, in that case, you would chew one tablet, take it with a carbonated beverage, so carbonated water if possible, and just to help speed up the onset of action so you get back to sleep sooner. In cases where you find that you do have to take a dose, usually it's a conversation that you've already had with the doctor saying that this is an issue that you've been having at night, and the doctor, neurologist, movement disorder specialist has already guided you that this is kind of the supply that you can take for the middle of the night. So if there's any changes, of course, I always tell people just to communicate with your physician if these symptoms do occur, because of course these are possible strategies, right? Possible strategies, so it's different for everyone. And then what I also said before was about possible side effect of medications, right? So some medications are best taken earlier in the day or in the morning. So when we're thinking about Parkinson's medications that might have insomnia as a side effect, I'm thinking about the MAO-B inhibitors such as selegiline, rasagiline, and safinamide, as well as amantadine, which is used for dyskinesia. So in some cases, if people are experiencing or if some people are taking rasagiline, I would tell them, take it before lunchtime, maybe take your dose, because rasagiline is a once a day medication, taking it first thing in the morning with breakfast, or if you have, your second dosing of medication for the day is 11 or 10:30, that's fine. In regards to selegiline, it is dosed twice a day. So for some people, they might take their first dose at 7:30, 8 a.m. in the morning. I usually recommend the second dose would be early afternoon. Some will say, 12 p.m. I would be all right even if it's just 1 or 2, just because it's earlier in the day and it shouldn't disrupt your sleep at that point. And then the same thing would go with amantadine, right? Because amantadine can be dosed 2 to 3 times per day. So same thing, it'd be amantadine first thing in the morning, 7:30 or 8, for example. And if it's twice a day, I would take my next dose before 3 p.m. So 12, 1 or 2. And if it's 3 times a day, then it just changes it to maybe 7:30 in the morning, arbitrary, everyone's different. It'd be 7, it would be 11, and then maybe 3, just to get your 3 times a day. But it's not a hard rule, but I think if I'm thinking early in the day, I usually kind of make 3 p.m. just my cutoff as my last kind of daytime medication, because I'm just concerned about it affecting the sleep of individuals later in the day. And then we have to talk about our non-PD medications that have insomnia as a side effect. So I listed venlafaxine or bupropion. Those medications are used for mood, and they can be quite stimulating. So again, just first thing in the morning or just before the late afternoon is what I would do with these medications. Some other factors that we have to consider would be the nocturia. So the frequent awakening, in the middle of the night, you're getting up more than once to use the washroom. And this can be due to bladder dysfunction, right? So often just the most common would be a hyperactive bladder, which presents itself in the form of urinary frequency, urinary urgency, right? So that this urge that you can't fight off, and you have to go, and you have to go right now. Or frequency as well, where you just have to go frequently. That's where you're getting up in the middle of the night. Causes for just bladder dysfunction would be just the degeneration or loss or decline in the nerve cells that actually control our bladder directly. So that's, of course, just the non-motor symptoms associated with Parkinson's disease. And of course, my concern in cases where people are getting up in the middle of the night to use the washroom is just the risk of falls, right? If, trying to navigate yourself down the hallway to the bathroom. So of course, just little strategies, there's just kind of little night lights down the hallway just to help guide your way. But definitely if someone's getting up in the middle of the night constantly to use the washroom, then it affects their sleep. They're feeling groggy the next day. So there are different options that you can talk to your doctor about if this is the case and you are experiencing a hyperactive bladder, essentially. However, there's also could be other issues that we might have to investigate further, and that could include such things as sleep apnea, right? So with sleep apnea, essentially what happens to your breathing during sleeping is it's stopping and then starting. So you're just taking pauses throughout the night where you're just not breathing while you're sleeping. When that occurs and it interrupts your sleep throughout the night, some people might not even experiencing it, but the partial or complete collapse of the airway, right? What happens then is the oxygen level in our blood drops, and then essentially because our brain kicks in, it will suddenly we're just waking up and gasping for air because the brain's not getting enough oxygen, right? So with sleep apnea, you're getting that shallower, more fragmented sleep because your body's constantly having to wake up to, hey, I need oxygen now. And then you're drifting back to sleep, but then it's just going to happen again. So with that fragmented sleep, you're getting, drowsiness and sleepiness during the day. In cases where it might be sleep apnea, that would be a case where, they might have to put you in a sleep study and just testing and monitoring you while you're sleeping just to see if that is indeed the case. And then for males, to go back into just bladder-related issues, for some males, it actually might be an enlarged prostate, right? With an enlarged prostate for males, frequent urination can also appear in men with prostate problems, but often it is accompanied by a slow or a hesitant urine stream. Some other symptoms of an enlarged prostate would be, of course, the frequent need, like I said, about having to go up frequently at night to go to the washroom. But then it's that difficulty starting urinating and just the weak urine stream. And you might find that it's slow to start. The stream is a little bit slower. There might be a little bit of dribbling at the end of urination and just a sensation that you feel like you can't completely empty your bladder, right? So with that being said, a hypoactive bladder in this case is uncommon, but some people with Parkinson's still might experiencing it, right? And the thing to add is not all bladder problems in people with Parkinson's is caused by the disease itself. That's why we might have to investigate if it is for males an enlarged prostate. So if you are seeing your urologist, it's important for men to make sure that their urologist is also aware that they have Parkinson's, right? Just because the treatments are different, right? Treatments for hyperactive bladder versus an enlarged prostate is different. So in some cases, obviously, if it's a bladder issue related to Parkinson's, in that case, you wouldn't need a surgical operation. Whereas for people with an enlarged prostate, they might need surgery, right? So it really, as you can see, just different treatment options. So you just got to make it clear when you see a urologist that you do have to disclose, of course, and they might know at that point that you do have Parkinson's, because it is a different treatment pathway that they would take. Okay, so now that, I talked about the sleep hygiene, I talked about looking at the medications and maybe doing more further investigation, I'm talking about some possible medication options that you might see. So I'm going to first start off with melatonin. Melatonin is a hormone produced by the body that has a role in regulating the body's circadian rhythm. So it helps promote sleep. So usually with melatonin, the melatonin's levels usually rise towards the end of the day, helping signal to our body that, hey, it's time we're going to go to sleep soon, right? And when it's dark, our body releases the melatonin to just kind of kick our, sleep-wake cycle into the sleep cycle part of it. They have found that individuals with Parkinson's actually show a decrease in the melatonin surge at night and lower melatonin production compared to controls, right? So it actually is something that they've seen with people with Parkinson's, that melatonin levels just aren't the same and they're lower. So that's why you can see why melatonin has been a suggested option to help with sleep. With melatonin, just from my experience, melatonin, people have reported that they might find that it may help kind of get them to sleep sooner, so that reducing the sleep latency. But often with melatonin, I've had people come and tell me, it doesn't keep them asleep. It helps them get to sleep, but they're still waking up at 2 a.m. So it's a different experience for everyone. The studies that have been done, individuals have found that melatonin may help improve their sleep quality. So that is a very subjective experience, right? Because this is what they perceive for themselves. But then when you're actually looking at the objective, they found that the total increase of sleep time is small. I added limited evidence because a lot of these studies, right, it's limited, so there's not a lot. Some of these studies are small as well, so there's just limited evidence to really confirm the efficacy of melatonin to be used in individuals with Parkinson's disease. With that being said, I know some people do try it. They go to their naturopath, or their family physician suggests. So, it's something that you can try after, consultation with your physician, but definitely make sure your pharmacy and your pharmacist is aware that if you are going to engage and start using melatonin. Side effects of melatonin include headache, dizziness, irritability, abdominal cramps, and fatigue. So everyone's different. Of course, I list off side effects, but not everyone experiences them. It's just something that I do want to make people aware of. And then I want to talk about a non-prescription sleep medication that comes up quite a lot, and that is diphenhydramine. So when we go into the drugstore, we might see it advertised as Nidal, right? Sleep Ease or ZQuil, as well as the pharmacy that you go to, they might have their house brand or, a pharmacy brand or a Shoppers Drug Mart brand or Safeway brand of diphenhydramine as well. So it's the same medicinal compound. I also want to highlight that diphenhydramine is Benadryl. So when you look at Benadryl, it is diphenhydramine. It just might be at a different strength, but it's exactly the same medication. It's just advertised differently. The other thing I want to highlight here is Benylin is not Benadryl. So just remember, Benadryl, Benylin, totally different things, right? So Benadryl is diphenhydramine. Some side effects with diphenhydramine is the grogginess, the morning drowsiness, so the next day hangover effect, dizziness, dry mouth, urinary retention, constipation, psychomotor impairment. So of course in that case it affects your balance, it affects your hand-eye coordination, which would affect your driving, affect your movement. And then we can have cognitive impairment as a side effect. So in that case, we're talking about your ability to process your thought processes, your thinking, your memory, right? So it just changes those aspects, or it can affect those aspects rather. And just looking at the side effect profile, you can kind of see why it's a no. But the other thing is Benadryl, diphenhydramine, sleep ease, Nidal, it is not meant for chronic use for insomnia. And I always make this a very important counseling point when I'm talking to my patients, whether they have Parkinson's or not. It's not meant for chronic use. It's meant for short term. So say, for example, if it's been, for some people, if work has been stressful, they're going through a very stressful event, possibly the loss of a family member, whatever it may be, that's when you might use diphenhydramine. That's when you might use sleep ease to get to sleep. But with that being said, it's meant to be used intermittently. It's not meant to be used every day. So say, for example, when I do suggest it, I usually always tell people, try to use it only 3 to 4 times a week and maybe just 2 weeks max, because what happens is tolerance develops, and you might find that maybe for the first couple of nights that you use it, it works really well. But as time goes on, it just doesn't provide you with the same sleepiness effects, and you just find that it doesn't work as well. And it doesn't work as well because that's just how the medication works. And that's why it's not meant for chronic use in insomnia. In cases where people are having trouble sleeping, that's when I always bring up the subject of, it's something to talk to your doctor about if you've been finding that you've been having trouble sleeping and it's been more than a couple of weeks and it's been like a long-term issue, right? And to go back to looking at the side effect profile, as well as the fact that it's not meant for chronic use, I say at the bottom of the slide, should it be used in individuals with Parkinson's disease? No, because of exactly what I just said. It's just unfavorable side effect profile, and the fact that it's not meant for long-term use, and often because, insomnia for those with Parkinson's, it's a long-term issue. So we have to think about other strategies to go about it and to treat it. So the next one, a possible option, now we're going to start talking about prescription options. So Doxepin is an option. Doxepin is in the same family as amitriptyline, for those who might be or know of amitriptyline, nortriptyline as well. Doxepin at higher doses, so 25 milligrams and up. I put 25 milligrams because that may be a starting dose or an initial dose that someone might be started on. And it can go up to as high as 300 milligrams for Doxepin. But often at the higher doses, you're using it to treat low mood or depression. But Doxepin is actually formulated at lower doses. So they actually also come in 3 to 6 milligram tablets. And those tablet strengths is what is used for insomnia. In regards to Doxepin, it can help with sleep maintenance. So it helps you stay asleep, and that is often the common problem in individuals with Parkinson's. Some counseling points with Doxepin is it's recommended to not take Doxepin within 3 hours of a meal to help decrease the risk of experiencing next day drowsiness. Because what happens when you take Doxepin with dinner, for example, or too close to, food actually delays the absorption. So it increases the risk of experiencing the next day drowsiness. Side effects with Doxepin include drowsiness, sedation, and nausea. And of course, you're looking for those side effects, or you're looking for that type of mechanism of Doxepin to get you to sleep, right? But of course, it is always a concern, like what I just said, about just possibly next day impairment. Even if you feel fully awake, you feel wide awake, it may still affect your driving. Also, in regards to the side effects, like I said at the top of the slide, Doxepin can also be used for low mood, right? But at higher doses, instead of the kind of side effects we see, like just as drowsiness, sedation, you get more of the anticholinergic side effects. So at higher doses, when you're going 25 or when you're going up to 300 milligrams, that's when you might experience, dry mouth, blurred vision, constipation, tachycardia, which is increased heart rate, Whereas when you're taking it at the lower doses of the 3 to 6 milligram range, that's when you kind of have more of the antihistamine effects of the drowsiness and sedation. So for some people, this might be an option. Definitely, obviously, something that you would have to talk to your doctor about. And yeah, so that's that. And oh, sorry, let me just go back. Just something to add about Doxepin too, and I'm going to touch on it again with my later slides. But with the Doxepin, it might actually be a good option for patients with a history of drug misuse or drug abuse or dependence, and I will show you why in the future slides. So just have that in mind. So another option would be sedating antidepressants. So some medications for mood, they can be extremely sedating, right? So an example would be trazodone. So with trazodone, it's one of those medications that are generally used for low mood, and the dosing when it is used for mood, I think the max is up to 600 milligrams a day, which is 600 milligrams, quite high. Usual dosage is usually around, for mood, 300 or 400 milligrams. When it is used for sleep, you might see something around 25 to 50 milligrams. You might even see 12.5. It's different for everyone. But essentially, you can see the difference on when it's used for mood versus when it's used for sleep. But still, we have to think about the side effects. So we're thinking about the drowsiness, possible headache, dry mouth, and orthostatic hypotension. So the side effect you most likely have seen before, because I brought it up before for some of the medications used for Parkinson's, but it's that lightheadedness when you're standing up from a sitting or a lying down position. And obviously, when we have that as a side effect, that dizziness, we're always concerned about the possible increased risk of falls, especially if someone's getting up in the middle of the night to use the washroom, right? So that's why we have to think about the side effect profile of medications when we are using them for sleep. The next medication that is also a sedating antidepressant is mirtazapine. So the dose of mirtazapine that is used for low mood or depression is also generally the same dose that you might see be used for the kind of sleepiness effects of it to help people get to sleep. So usually with mirtazapine, it could be in the range of 15 to 30 milligrams at bedtime. In some cases, I've seen 7.5 as well. But I just wanted to highlight here that it's one of those medications that if someone has, a mood disorder, in addition to having trouble sleeping, mirtazapine might be a choice if the doctor thinks it's appropriate. With the side effects of mirtazapine, there is the side effects of sedation and weight gain. When people ask about weight gain, they ask, am I going to constantly, be gaining weight throughout the whole duration? For some people, if they do experience weight gain, it's just when they start the medication, it goes up, X number of pounds, and then it stops. You don't keep on going up, but it's something to be aware of. And with that being said, in regards to just any side effects, sometimes side effects are more prevalent at higher doses, right? So in cases where someone might be taking, above 30 milligrams in some cases for mood, then, that might be a time where they might experience weight gain. But with that being said, everyone's sensitivities are different, right? So just something to have in mind. Okay, and now we're going to talk about our benzodiazepines. So this is one of those classes that you probably hear, the red flag comes out. People are like, no, don't take benzodiazepines. And I'm going to explain why. So some examples of benzodiazepines: lorazepam, temazepam, oxazepam. Those are the ones that you might see be used for sleep. Generally with benzodiazepines, it's to be used only for the short term if possible. So when I'm thinking short term, possibly, 2 weeks, 2 to 4 weeks max. It's, arbitrary, right? So everyone's a little bit different, but the main thing is you don't want to use it for long term, if possible. The concerns with the benzodiazepines are they're habit forming, right? So it might get to a point where your body can depend on it to fall asleep. tolerance can also be an issue where, for the first little bit, you're finding that this dose works for you, but then you become tolerant to those effects, and then you essentially need a dose increase. You become tolerant to that, and then you need more and more. So tolerance can be an issue. Cognitive impairment, right? So we're thinking about our thought processes. It's affecting our ability. It's affecting our ability to think and process through problems. It's affecting our ability to remember things, right? Our memories, those are big concerns. So obviously, I think with any sleep medication with this type of side effect, if someone is already experiencing memory issues, then you want to stay away from these type of medications because it can make it worse. And this can also be a concern in our older patients, right? Our elderly patients, because they can be more sensitive to these side effects. But yeah, just going back to cognitive impairment, it can also, in addition to affecting our cognition, it can affect our coordination and our balance, right? So with the benzodiazepines, if you're already feeling not so steady on your feet, if your gaits, and you're already having issues with balance, when you're taking a medication that could possibly increase your risk of falls and fractures, it's just something that definitely you just wouldn't want to have. So in this case, you would want to avoid a medication class like this. And of course, just getting up in the middle of the night, right, to use the bathroom. Like I repeated before, if a medication is affecting our balance, that's definitely something we have to be concerned about if we have to get up in the middle of the night to use the washroom. With the benzodiazepines as well, like with some of the other medications, it can cause next day impairment. So that possible hangover effect, even if you feel that you're fully awake. So of course, that the concern there is if we have to drive to get to work or get to where we need to go. And with the benzodiazepines as well, rebound insomnia upon withdrawal. So rebound insomnia is if you were to stop the medication cold turkey, which you would never do with benzodiazepines, you might find that when you might get insomnia that is worse than what you had before starting the medication. So it would act, if that makes sense, right? I know it's just insomnia that's worse than before you started the medication. Examples or symptoms of withdrawal would be insomnia, nausea, twitching, anxiety, irritability, so just changes in your mood, vomiting, delirium, and the main thing that's obviously very concerning would be seizures or convulsions, right? So that's why you never ever stop the benzodiazepines abruptly. You always taper off slowly, because the thing with benzodiazepine withdrawal, it can actually be life-threatening, especially when you think of seizures and convulsions, right? So it's one of those things, especially when I have patients that based on the fact that they've been using it for a long time, for example, in their case, it's definitely something that their doctor, if the doctor wants them to, slowly kind of just decrease their benzodiazepine to the point where they want them off of it, it's always going to be a slow taper, often. Yeah. So next one would be zopiclone. So zopiclone is not a benzodiazepine. It's a non-benzodiazepine, but it has benzodiazepine-like properties. So we're still concerned about the chance of developing tolerance, developing dependence, cognitive impairment. So we're thinking about affecting our memory, affecting us to think through problems, affects our ability to possibly even, especially with the benzodiazepines too, just ability to do, like, we're forgetting something that we just learned 5 to 10 to 15 minutes ago. So just the making of memories and thought processes, and just increasing our risk of falls, right? So of course, again, just getting up in the middle of the night to use the washroom. If you're feeling groggy, increasing your risk of falls. With zopiclone, they may cause less rebound insomnia upon withdrawal, but with that being said, it's may, right? So in this case, with sleep medication, especially with zopiclone, we still have to taper. So we're decreasing the dose slowly. And with zopiclone too, it does come in different tablet strengths, right, to help you with the tapering process. again, with this one, like the others, it may cause next day impairment, so that hangover effect, even if you feel fully awake and wide awake. The concern there is if you have to drive, right? So the counseling point, it's actually advised for zopiclone is that you should wait at least 12 or more hours before driving or operating heavy machinery with the zopiclone. I didn't include it on here, but zopiclone also has a bitter metallic taste, so just something to be aware of. Okay, so I think most of you or some of you may remember this. So it was last year, and I remember getting a lot of questions about U-Dream. So U-Dream was a herbal remedy that was on the market. A lot of people were asking for it. I think some pharmacies actually sold out of it, but it was a herbal sleep aid. Essentially, the end of last year, herbal U-Dream was recalled, taken off the market. And when I was looking into it, I would have people coming and asking me if like, oh, is this safe for me to take with my levodopa carbidopa? Does this interact with any of my Parkinson's medications, right? So, I would try to do the check, which I'll go into, but eventually it got to the point where it was recalled and taken off the market. And I remember looking up to, Health Canada and just looking into it. And Health Canada was actually advising Canadians that, they tested the U-Dream product and they found that it contained a substance that was similar to a prescription sleep aid, a prescription sleep medication, which was zopiclone. And of course, in that case, it can pose possibly serious health effects. And the reason why Health Canada started testing these U-Dream products is because they were receiving complaints about people experiencing symptoms of withdrawal and dependence, suggesting, and to them it suggested that there might be something else that's in the U-Dream product that wasn't listed on the product label, right? And because I just talked about zopiclone and, talking about possible things that you have to be aware of with, the dependence and the tolerance and, tapering off slowly, for the, Health Canada to see that people are taking a herbal sleep aid and experiencing those symptoms, it got the gears turning that there must be something in the U-Dream, and that's what they found. It was just something that resembled, something that was similar to zopiclone. So, after all of this, and, even when U-Dream was on the market, I would try to do an interaction check for people. And in addition to just, the case of U-Dream, it's just because it's marketed as natural does not mean it's safe. It also brings up the issue with when I was trying to do an interaction check and looking on the side of the box, a lot of those ingredients I wasn't actually able to find in my drug interaction software. So, I would always enter all the different drugs that an individual's on and then anything in their natural health products, right? Sorry. And in some cases, I just couldn't find anything. So I was left in a position where I would just have to be outright and honest with the patient, saying, I tried to do a U-Dream interaction and I just couldn't find the ingredients, like they're not in my software. So I can't tell you, confidently if there's any interactions or not. And that type of situation, it brought up so many other concerns about safety and efficacy, right? Because with these natural health products as well, if I can't detect the drug interaction, it's really hard to confirm if there's any interactions with the medications. Of course, they're taking not just the Parkinson's, but any other medications they're taking for, blood pressure, if it's for their mood. And in some cases with these natural health products too, there's safety and efficacy concerns in regards to health conditions, right? Because sometimes natural health products, what they might do is they might make it so they increase your blood pressure, or they might make it so that it increases your risk of bleeding, right? And this could be concerning if you're on something like an anticoagulant to help prevent clots from forming, because you're one of those individuals with atrial fibrillation or a history of heart attacks or stroke, right? So in this case, it's just, there's always just safety and efficacy concerns regarding natural health products, and we just have to be more cautious. And I put this on my last slides before, just in regards to any natural health product, just make sure that you talk to your pharmacist about it, just to see if they can possibly check for interactions. So with that being said, counseling points in regards to just sleep medications is you use them on an as-needed basis if possible. You always want to use the lowest effective dose. And with sleeping medications, it's best when they're combined with non-drug measures. So if you are using a sleeping medication, you would want to take your sleeping medication 30 to 60 minutes before bedtime while doing a non-stimulating activity while you're waiting for it, like the effects of the medication to kick in. So in that case, of course, we're not talking about no television, no mobile phone, no tablet or laptop. You're just possibly meditating, listening to some nice calming music. You're just reading, in this case, a paperback book under light, just a little bit of light so you can see the pages, see the words, but you're not doing anything stimulating. So the take home is, a lot of it is non-drug measures. It's always the first thing that we want to key in on, because they do have such a tremendous role in helping treat insomnia. And in some cases with PD medications, just the medications you're using to treat the motor symptoms, you want to make sure that you're managing your meds in a way that you get that control overnight, so that hopefully you won't be waking up in the middle of the night feeling rigid or stiff or pain. And if sleeping medication is needed, just remember to be aware of the associated side effects, right? So just the side effects of possibly the next day, how it affects your next day functioning, right? The concerns about feeling awake, it might still affect your coordination, your ability to drive, right? So it's just definitely things that we have to think about. And just to go back into just counseling points, I think, whenever you get any type of sleep medication, the pharmacist should be counseling you on, you're not being mindful of taking medications that can cause drowsiness together, right? So a mood medication with a sleep medication with a pain medication, those sedative effects, right? Just the compounded drowsiness. And of course, being mindful of our alcohol intake with sleeping medications, that's a no-no, right? You don't, because again, it's just gonna increase the sedation, and there's obviously safety concerns there. So when we're taking just medications, we just have to, of course, just remember the side effects and how they might impact other things that we're consuming. And that is my presentation for insomnia and Parkinson's disease. And yeah, please, I left my email on my website up there. This is my last webinar with PSBC for now. But if you have any questions, I'll see if I can answer them. Of course, when people email me questions, I don't have your full medical history, so I might be able to answer the questions. It just depends on the situation, what type of question you're answering. But thank you so much for those who attended these webinars from the beginning. It's been a really good experience. So thank you so much to PSBC as well for having me. It's been great.